Hey everyone, recently myself and Jelly, we sat down with Alison Sim at the 2016 National Osteopathy Australia Conference. To tell you a bit about Alison Sim, she has a keen interest in educating health professionals about the latest science surrounding pain, especially that hangs around, like chronic or persisting. She just completed her Masters of Pain Management through the Sydney University Medical School and Royal North Shore Pain Management Research Institute. Alison's goals in teaching on the topic of pain are to take the science to help practitioners translate it into tangible, clinical concepts and tools. Alison is also an avid blogger and teacher. She has lectured at the Australian Catholic University, Victoria University, and RMIT in a variety of science and clinical subjects. She's also worked as part of the teaching team at Deakin University Medical School and is currently based in Portland, Oregon, USA. You can read her blog as well as book her for guest lecturing appearances via her website www.beyondmechanicalpain.com. We're good. Alison, welcome
Thanks
to
for having
Semantics Podcast. We're going to dive straight into it because we've all got places to be and it's been a long day.
It certainly has.
But firstly, your presentation was absolutely spectacular.
Thank you very much.
We both
I felt really switched on through the whole thing from start to finish, and I couldn't help but think, I wish my friend Lisa was here. And then there were all these other people that kept popping up in my mind, like, oh, if Michelle could hear this, or if Megs could hear this, like, I wish I was recording that entire presentation from start to finish.
That's very kind of you. Given that it was 4:30 till 5:30, and going up against Letterman, I think we can take a couple of things from that. One is that the conference organisers don't like me very much.
hear that, Osteo Australia?
No, just kidding. Thank you very much for staying awake and giving me smiling and encouraging nods throughout.
Not a problem at all.
And thank you for sharing your time with us here and now.
Thanks for having me.
Yeah. So, what is the paradigm shifting science that is emerging on pain and chronic pain more specifically?
So the paradigm shift that we're talking about is the move away from the essentially the biomodels that we have always focused on as osteopaths and all manual therapists essentially, which focuses on the idea that we're looking for a tissue-causing symptom or something that we can put our fingers on or diagnose quite locally. Which in the acute setting is often quite appropriate. We're really looking for nociception, we're looking for tissue damage, those kind of things. However, what we understand a lot better these days is that what we see in the acute setting physiologically doesn't necessarily translate through to the chronic phases. So what we see are some changes within the nervous system, both in the peripheral and central nervous system, that almost essentially change the way we need to approach chronic pain. And we need to approach it from a more biopsychosocial approach. So a lot of what the presentations this afternoon focused on, that idea that what we see going on centrally, particularly in the brain in chronic pain, so we often see dysregulation with those central modulatory systems, peripheral sensitization changes. We see changes in that dorsal horn where we get upregulation of the receptors that Phil Austin was talking about. So that nociceptive information can both travel up to the brain with a lot more efficiency, but also is less inhibited by those natural innate central inhibitory control systems that we have. And what we tend to find is that in the presence of fear and anxiety and worry, which ultimately for us as clinicians presents itself as a lack of understanding of a person's condition, that those limbic systems of the brain fire themselves up, that we get higher activation of the sympathetic nervous system and higher levels of circulating cortisol. And in the presence of those factors, that limbic system seems to get more wound up. And when that does, it does tend to either decrease the descending modulation, which obviously ultimately results in greater nociception, but in some cases it can actually increase facilitation. So It can increase facilitatory input down from the brain and to the periphery to essentially go looking for nociception. So it's like the brain's way of saying, hey, I'm really worried about what's going on here. There's thoughts and environmental conditions that are saying that this is something I need to worry about. Can you tell me more about what's going on in the periphery? So it almost facilitates the nociception so that it can get a better idea.
Yeah.
Which in a threatening environment, if you've got the lion chasing you all the time, that's really appropriate. But for most people who sit at desks and do that kind of thing, it's not so appropriate, and it ends up being quite unhelpful.
Yeah. And that just reminds me of a really helpful slide that Phil Austin put up while he was doing his presentation. And it was pretty much just 2 columns. Guys who are listening, I'm going to upload this onto the comment section when we upload this podcast. But 2 columns, one that says gate openers and one that says gate closers. So things that sort of enhance or facilitate or encourage that stimulation, that nociceptive input, and then things that sort of help, reduce it or alleviate it.
Yeah. And they're often, they're essentially modulators of fear. Ultimately, is what it comes down to. And the way we would measure that is there pain catastrophizing going on, and is that about a person's thoughts, and can we address those thoughts to help them feel a bit more comfortable about their condition, and therefore with those safety understandings, those safety cues, can we naturally start to boost those descending inhibitory systems so that their pain event is less.
Yeah. And it's such a different perspective, and one, I suppose, for me, I'm only a second year, but hasn't been put to us yet. Probably will be in later years.
Yeah.
But yeah, something that we haven't really investigated. After doing neuroscience and only just learning what the periaqueductal grey is and things like that, it's not really something that has been explored.
No,
yeah.
not at
So
all.
I think there's a couple of things with that, Jelly. One is you do need to know the basics first. If you want to know how, if we want to learn about pathophysiology, we first of all have to understand physiology really well before we can learn what goes on with it. And so I agree with that. The other thing I think it brings up is this idea that you said the word paradigm shifting, and that is exactly, you're on the money when you say that. So for people like me who went through, I went through 15, 16 years ago through uni, I graduated, it has been a paradigm shift. So it has, for us, we came away thinking that we should be able to fix everything with our hands, and that everything was amenable to osteopathic treatment, including the chronic things. That ultimately leads to this idea that when you can't fix it with your treatment, that you're not doing it right. And there kind of is that teaching, and that comes through with that kind of guru mentality when you have practitioners or industry figures who stand up and say, you have to treat this way and use this 5-step wonderful process or it's not going to get better. And that leads people to think that it is their manual skills that are lacking, and that's the reason that they're not getting the outcomes. When actually, once we understand pain science better, we know that that's just not the case, that it is these central changes in the brain and spinal cord that are ultimately perpetuating that situation. And treating the bio parts of that is really important. And we do need to have, you never want to get to a point where we're bio-denialists, where we're denying the contribution of bio. I think we're very far off from that. It's not going to be something that happens in the near future. It is a tendency that pain nerds like myself can find themselves falling into that trap of denying the contribution or the bio bits, the biomechanics, the anatomy, the physiology, the inflammatory bits that play into a pain condition. And putting too much emphasis on the cognitions, which is the psych part of a biopsychosocial approach, and the environmental bits, so the other parts of the social context of the environment,
factors.
the environment that pain event sits in. So it's not to deny that they don't have a role. They really do have a role, and like in your learning, you need to be good at those going forward. If you're going to deliver manual therapy as part of your treatment approach, it needs to be good. So you need to get those good foundations. However, I wish, as a new grad, and I wish as a practitioner I'd known this from day one in my training, because it means that you don't have to have that moment 5-10 years out when you're starting to learn about pain science and you're scratching your head and you're thinking, oh, this explains a lot. But it's often quite confronting, because you're learning that, you know, the science says that manual therapy is not very effective for chronic pain conditions, and that in a way can be seen as quite delegitimising and threatening to practitioners. The temptation then from that is to walk away from it and think, well, I get good outcomes and I'm good at what I do. I don't need to look into that pain science nonsense because it doesn't fit with my biases.
Right, yeah.
And so that's usually the first step that practitioners who are learning about pain science have to get over. And some of them don't make it over there, and then others that do and push through look back and say, look, there's some real positives to understanding this, because you can take it and run with it and get, you know, I guess evidence-based better outcomes. Yeah. But also it stops that idea of, you know, when things don't go as well as they should, that it's your fault, that it's your lack of manual skills or, you know, how good you are at diagnosing things that is the problem. It gives you a much bigger, I guess, a more global understanding of a pain event.
You mentioned earlier that some pain practitioners don't quite make it through.
Yes.
What did you experience that, and what was that critical factor that allowed you to go, okay, there is a light at the end, well, not a light at the end of the tunnel, but I can get through this?
I certainly did. So I remember coming to the Gold Coast AOA conference, and it would have almost been 10 years ago, and they had a speaker there whose name escapes me because I'm jet lagged and very tired. It'll come to me in a second. Who has a PhD in pain science, and he was speaking about outcomes in chronic pain and just essentially presenting that science, that quite bleak science that says that manual therapy really is not particularly effective. And I just remember that cognitive dissonance and the resistance that popped up in me. That on one hand I was fascinated by the research he was presenting. On another hand, I found it incredibly threatening, because I thought, well, it means that you're taking away everything that is important to me and everything that I stand for. And, you know, perhaps had that message been pitched slightly better, I mean, it's only so much you can fit into a 1-hour presentation, but had I heard that message with a bit more context of what it means and how you can integrate it into your clinical approach and why it doesn't have to be threatening, perhaps I might have made that leap at that time, but I chose to run away from it and go back to practicing in a way that was safe and comfortable for me, which is, you know, largely manual and structurally based. It was my own experiences with pain and with chronic pain that led me to pain science. So I'd had chronic low back pain. Following the birth of my children, it went away while I was pregnant, which is often quite common. And then it came back with a vengeance after my second child, because I really deconditioned between the two pregnancies and then got quite fearful about it. You know, how am I going to get this better? I've now got 2 children to look after. At that time I was incredibly sleep deprived, which is often what happens when you have a new baby, and I didn't take into account the role that was playing. And I still had that very structural focused approach on low back pain. So my understanding at the time was that there was facet joints that were really stuck and stiff, and the muscles needed to be stretched and MET'd and all of that kind of stuff, and it would just get better with that kind of treatment, and it didn't. So I was getting a lot of treatment. Then you get to that desperate stage where it's really starting to have an effect on your life, and you think, I just need to find the right person. And this is often the pattern that we see chronic pain patients going through.
Really?
I need to find the right person, the right modality, the right thing that is going to take that pain away from me. So that's that real passive mentality. And so it was at that time that I started to read a bit more about pain science, and I was going through the book Explain Pain and starting to discuss it a little bit more. And again, that cognitive dissonance comes up very strongly, in that I'm not stressed. This is a tissue problem. This has nothing to do with my lifestyle factors. It has nothing to do with my cognitions. I'm a practitioner and I know everything there is to know about low back pain.
Which goes against the biopsychosocial model that us osteopaths are intrinsically taught.
To go looking for that tissue-causing symptoms. And, in hindsight, I was the classic biopsychosocial case that really needed to get that proper understanding that because that condition had been there for 8 years or whatever, it was really unlikely to get better with someone's thumbs in my back. And just on really, I was really lucky that on the very simple advice of someone who I trusted and respected, I was told to just get strong. And that was as simple as it was for me, that message. Just get strong, don't think too much more about it. And so I did. I hit the gym a lot harder and with a lot less fear, really, even without much more instruction than that, and started lifting a lot of weights, doing a lot more deadlifts and squats, and found that my back pain just did get better. And I think, again, in hindsight, looking at that as a clinical outcome, part of it was just taking away the fear, his reassurance and saying, look, you're safe and this is going to... And then also his confidence to say, I'm confident that if you go down this pathway that you will get better.
Yeah.
The research is very strong out there that says if you include any kind of exercise approaches, my bias, because of that experience, is always going to be towards weight training and having some kind of weight components, that you're likely to get better. And so I still have very occasional back pain flare-ups, and when I do get it, it behaves more like chronic pain. So a bit like what Phil was saying, it doesn't have a lot of pattern to it. There's not a lot of rhyme or reason why it comes on, but it does seem to come on when I'm really stressed.
Right.
And also at times when I'm not moving as much, so when I'm not exercising. So that was my journey, and that's what brought me to understanding pain science better. Then I had a career crisis and decided I wanted to, I was really not happy with the way I felt my practice was going. And I felt like I had a couple of options, that I could get out of osteo and do something different. And then I found this Pain Masters at Sydney, and it really has allowed me to have that career crisis but stay in osteopathy and hopefully be able to continue, providing healthcare, which is something that, that's a value for me. That's something that's really important.
Yeah, it's great. Yeah. Well then, I guess on a personal level, I'd also like to thank you and Phil for those presentations, because it's helped me or educate me on my own chronic pain symptoms. So with that, again, reassurance and having that knowledge now, I feel like, well, I have had a couple of osteopathic treatments since to help me understand the mechanisms, what's going on underneath it all. But for the last maybe 3 or 4 years, I've been having issues with my SIJ and massive restrictions, and the whole getting over, the fear avoidance behaviours and just getting back into moving again. I now, in retrospect again, it's just that that very typical case.
So essentially what you're describing is you've just sat through 2 hours of pain education. Essentially.
Much,
and the goals of pain education, when we talk about it, are threefold. They are to separate pain from tissue damage, because that in itself is a safety cue. Yeah. If you know that pain is not reflective of tissue damage, you're far more likely to tolerate a bit of pain in the pursuit of rehabilitation. Yeah. So if you know it's not causing you, if it's not a threatening signal, it takes away a lot of the fear around it. Take away the fear, you increase the those descending modulation, and you're likely to feel a lot better. The other thing that we do with our pain education is try and separate to point our goals towards function rather than looking at take away pain, and that's
so in regaining function rather than decreasing pain.
Yeah, we know that dropping pain scores is a really tough gig. As I sort of mentioned in my stats, there's not many interventions, and even the really gold standard multidisciplinary clinics, they often don't knock the pain scores very much, but they do smash the functional outcome measures. So they get people back moving, they get people back to doing the things that are important to them. And if we're setting out a pain education or a pathway for a patient, so a plan is the word I'm looking for. We need to get them to understand what our rationale is and what our goals are, and telling them that we're going to focus on function, and the pain might sort itself out. It might drop off, it might not, but that often you ask people that magical question: what would happen if I took your pain away? What would you be doing? It's often just the lack of doing those things that have meaning to them that are the most upsetting in a pain event. And so that kind of starts to introduce the concept that in the presence of pain, you might be able to get on and keep living your life.
Yeah.
And sometimes what we find is when we do that, when we've put that emphasis on function and not so much on looking at pain scores, that the pain does tend to often drop away. Or that people aren't so focused on it, so it doesn't have as big an impact in their life. So they don't describe themselves as having pain quite so much, or it being a central focus. And then the third thing that we do with pain education is try and underpin management. So you're saying this is the physiological basis for doing exercise. Exercise is often quite a hard sell for people who are scared of moving and who aren't used to moving. So to get them compliant with that, and sorry, compliance is a horrible word, underpinning it with physiological understanding for them can sometimes be really good. And the same as what I talked about in the talk, to get a psychologist on board, sometimes that can seem near impossible. But if you can physiologically underpin it by drawing those areas in the brain that get, the limbic system, the amygdala, that just gets absolutely ramped up with fear, that drives those cortisol levels, that drives that sympathetic activation, that lower, you're drawing all these pictures and you're showing them this is what happens when your thoughts influence your physiology, and therefore this gives us a reason that seeing a psychologist is going to influence the thoughts and might have an effect on your pain. So you're physiologically underpinning your management, essentially, and that sometimes can help with the uptake of the bits that are a bit more unpleasant for the patient.
So to me, by decreasing pain, by regaining function and not decreasing pain, how do you differentiate between that pain being guarding type pain as opposed to acute or chronic? Have you developed like any sort of measures upon that, or is that purely through the psychological?
We would say, so I think it's probably more about the way you're labelling it, Reece. So I would say that guarding pain would probably fall more into unhelpful pain, and which is what chronic pain essentially is. Acute pain is really helpful. It really helps us protect our tissues. It's there for a reason. Yeah. Chronic pain has no value to a being, and it's not rooted in survival. It's an aberrant physiological process that occurs. So does that kind of remind me what the question is?
I'm just trying to differentiate.
How do you differentiate?
Yeah, between guarding and, well, I guess chronic pain now would be the question.
So I guess the way you would look at guarding is to say it's essentially an element of fear avoidance. And fear avoidance comes about because often you have the wrong idea of what's going on in your brain. So if you, in your thoughts, if you are worried about, so for example, my aunt had a disc bulge that she'd had 15 years earlier, and she was told at the time that she should never flex her spine because it would potentially make the disc bulge worse, which in that acute setting is probably relatively appropriate. We do need to give that tissue some time to heal, and so flexion's probably not the greatest in those acute phases. However, she never went back for follow-up, and so 15 years down the track she was still putting her socks on very gingerly and using the long-armed sweeper to sweep the floor rather than bend down to use the dustpan and brush, because she had been told that her back was fragile and it needed to be guarded. And so that is a really good example. And she would have these catastrophic events where she would get in the car, which we would consider to be a normal amount of flexion that someone should have. But because it was at her end of range, that might have been enough for her to trigger quite a catastrophic episode of acute low back pain. So all we did to treat that was to de-threaten flexion and just reassure her that disc had well and truly healed. It had probably healed about 6 weeks 15 years minus 6 weeks.
Yeah.
And that flexion was a normal movement of the spine, and that it was safe, and that tissue was healed and scarred and was unlikely to get any worse. And she should start doing some flexion movements, gently graded flexion approaches in lots of different contexts, which she did, and subsequently hasn't had, she was getting 3 to 5 of these acute episodes a year, and hasn't kind of had one since. And her take on that was, you gave me permission. You took away the fear, and you gave me permission, and that was all she needed. So sometimes it is just resetting someone's understanding of what's going on. It just takes the fear away.
And that ties in really well with one of our questions that we had listed about the power of diagnosis, and sort of how clinicians will explain a diagnosis to a patient and tell them what's going on with their bodies, and how the term disc bulge could elicit worry and anxiety and fear because of all those stigmas attached to lower back pain things.
Yeah. So I think in answer to that question, the first thing would be not to have the MRI in the first place. If we know that about 50% of people my age, my very tender young age of 37, have 1 or 2 disc bulges,
Right.
and if your back pain doesn't mean that you need to go towards, if it's not going to change your management ultimately, it doesn't mean that I need surgery or whatever. Don't get the MRI in the first place, because there is likely to be something on there, and you are going to start putting ugly images in people's minds about what's going on. A bit like our exercise approaches, as we get smarter with our understanding of what's going on in the low back pain and what nociceptive or what's potentially has nociceptive capacity, we get simpler, well, I'd say dumber, but we get simpler in our explanations of what's going on. So we're really trying to move away from that tissue diagnosis, because we know it's unhelpful. So, the idea of telling someone that their pelvis is rotated, that really conjures up really unhelpful images in their head. And it does a couple of things. One is it takes them, it takes that idea of, if we label it as being simple pelvic pain or mechanical low back pain, something really simple, and we explain, look, we really don't know what structure is causing this, and it probably doesn't matter because it doesn't change our management. Whereas if we label that pelvis as being rotated, it takes that out of their hands, so it really disempowers them. And then the idea is then that you have to see someone to fix that, because you're broken. And I talked in the talk about active versus passive is one of the really strong foundational concepts in pain science, because active approaches just work a lot better than passive approaches. When someone is waiting for something or someone to take their pain away, they tend to get poorer outcomes. Whereas when they're empowered to do it themselves with things like stress reduction, activity modification, exercise, things that they're doing for themselves, they're far more likely to get better. And so with that picture in their head of pelvises being rotated, joints being out, tissues being tight or short, or they're really unhelpful images, because they really disempower, they encourage a passive approach. So we have this massive role to play in helping people to get better, but we have to be very careful about the language that we use and the images that we're creating with that language, and make sure that it is of a reassuring nature, that it encourages activity and active approaches, and doesn't threaten or disempower the patient.
Yeah. Okay. And I guess I just remember a couple of times where some of our lecturers have really tried to drill that into us. So I suppose I'm grateful that that is something that's being taught to us now as students, about taking the responsibility and having patients be reliant on us or dependent on us for treatment or to be cured, or having this idea that they need to see somebody to fix them.
Exactly. So seeing it as a partnership rather than a hierarchy where they come in and wait for you to do it all for them. And that's great that you guys are learning these concepts from the get-go, because they are, they perhaps weren't taught to us with,
when you were going through those years ago.
Something I was actually I've just been discussing with a couple of other practitioners that I've met today, was I have a bit of a concern about sort of all of these new up-and-coming like webinars and online courses and things like that. Do you feel like it sort of takes away from all the things that we absorb from face-to-face teaching and learning?
I think you can see it working both ways. So when I first graduated, I moved out to Orange in New South Wales, and there was we were the only clinic there. There was only 2 and 3 practitioners working in one clinic, and so it was incredibly isolating.
Okay.
So in terms of staying on top of the science, it was really hard to access. You had to drive 4 hours to Sydney, and so it was harder. So I think that opens up a lot of the access and means that people can get access to this information. But I think you're exactly right. There's nothing like sitting in a lecture and just thinking, wow, that is so inspiring, and that I'm going to take that. Not just the information, but it's often the feeling of like, wow, I feel really excited to go back and try this in clinic. I think nothing can take away from that. The other thing that's really good about coming to face-to-face CPD stuff is the interactions that you have. And
Absolutely.
They have so much value. Just the support that you get from that, bouncing ideas off other people's head, seeing what other people are doing. It's really motivating, and we have to look at ways to keep ourselves motivated once you get out there, because it is really easy to fall into those slumps in clinical practice.
And did you feel when you were a graduate that there were enough of those opportunities for you to interact and network socially with other people in the osteopathic community?
Probably not enough, but there's certainly getting more and more. The problem is the engagement, and that's what many of us who are running CPD are finding. It's really hard to get people off their couches to come and hear people talk. Probably because of the access to free information and web-based information, so that the actually physically turning up is harder. I don't know what else caused this disengagement. We were sort of saying that once upon a time the AOA, as it was named before, OA used to be able to run a CPD session, and they'd easily get 100, 150 people in Melbourne without too much trouble. It would be hard to achieve that nowadays. So we often feel like we have to actually create the connection first, and create the engagement with people to get them out of their houses before we can start bombarding them with more up-to-date research or more up-to-date information. So that kind of shows how people can come out of uni and just not stay up-to-date. So for all you students, make sure you stay engaged, because it's what helps you stay in the practice for longer. Come out and make sure that you do keep up-to-date with these things.
Yeah, great.
Awesome. Is there anything else you want to add in there? I know you've got your own little blog.
Yes, I do. So I feel really strongly that there's a couple of takeaways from my learning about pain science. One is that is the experience that a lot of people have, is that threat of pain science, that it takes away. And so my mission in delivering any kind of lecture or CPD stuff is always about taking the pain science and making it clinical. So what does this have meaning for us? What does this mean for me in my clinic? So I blog with that kind of stuff, so I'll often look at some research and then see what clinical implications are there. And that is the idea of a lot of my lectures, and I have webinars. So when you ask me about webinars versus face-to-face, I have a vested interest that I probably should declare.
I was more sort of concerned with sort of undergrads and people who are just coming into it, still sort of learning the basics, anatomy, physiology, and that sort of thing. I feel like at a time where we should be developing interpersonal skills simultaneously. So not just the theory, but the practicality of having a conversation with someone and not being socially awkward.
Yes.
So
that's a life skill, really, isn't
Absolutely.
it?
Exactly.
The other thing that I take away from the pain science stuff is, as I've kind of hinted, is I wish that and many of us who are my generation who are pain nerds wish that we hadn't had to go through that massive paradigm shift. And it is a sign of the times. It's not osteopaths alone who are going through this. The physios are doing the same kind of idea. The chiros are probably lagging behind a little bit with that because it does fight with a lot of their existing understandings. But you look at the industries like myotherapy, who just aren't shackled by a lot of the dogma that surrounds a lot of our industries and the history that drags it down. They're embracing this stuff with open arms. So they're kind of not held back the way that we are with a lot of that, philosophy stuff. And so, as I say, because I wish that, I see the way forward then is students. I think, we need to be teaching this to students from the get-go. They do need to be good at the basics, but it's okay to infuse this understanding from the start so that they're not having to turn their minds around about it. And therefore, yes, if you do go to my website, I do offer really good student deals, usually about 10% of the price that I'd charge for the grown-ups. Because I feel like they should be subsidising you guys, because I just think that's how we're going to change the industry. You guys are going to be that generation that go out and are using an evidence base in your practice and using that quite proudly, and you guys will be the one that take osteopathy forward. So check that out, or come along to the face-to-face stuff I offer quite cheap.
And we find your website on
www.beyondmechanicalpain.com. You can find me on Facebook at Beyond Mechanical Pain. That's right. Beyond Mechanical Pain is is my Facebook page, and Twitter Beyond M Pain.
Great. And for those of you listening, we'll provide a link to all those sources in our upload. We've just got one last question here for you. And that is, where do you see your practice in the next 10 years?
Oh, that's a really good question. So I'm currently not practicing at the moment. I'm living in the States, and I've just finished studying, and I've just handed in my last assignment for my master's. So I'm very keen to start skiing.
Cool. Well, congratulations, and it sounds well deserved. A bit of a ski trip.
I don't really know. I think the ultimate goal would be to be able to practice in an evidence-based way. So to have all the things that I would that I talked about in the talk. So having easy access to psychologists, easy access to someone who can provide exercise approaches, preferably all in-house, very coordinated, a lot of communication between practitioners, everyone with the same focus and the same idea in mind, which is not looking to cure a patient, but that eye on the prize, which is the function, and smooth referral to psychologists as well, so to make sure that they're part of it. Whether that means I start my own thing or whether I work for someone, I don't really know. Or I could just retire and play tennis sponge off my husband.
So were you thinking of maybe going back into teaching? Because it sounds like you're a really great speaker, and you put things so simply in such a way that's really easy to understand.
It kind of is the obvious way forward, isn't it? That if I got back into teaching, it ticks a lot of boxes for me. So yes, that could be a possibility, and everyone seems to think that the next step is the obvious PhD, but I don't think I've quite recovered from the masters yet to even consider that. So I don't know. It's a lovely place to be. That the world's my oyster.
Great.
Yeah.
Perfect position.
Yeah.
Absolutely. Well, congratulations on just completing your masters and all the success that you've had so far. We really look forward to taking a look at some of those webinars on your website, and
Beyond Medical Pain.
Mechanicalpain.com.
Yeah.
Thanks so much, guys, for having me. I really appreciate the chat.
Thank you for your time. All right, we're out.
Good one.
Thanks for listening, guys.
Before we wrap up, there are some thanks that need to go out. Friday Hut Studios provided us with the logo design. And for all inquiries, go to their Facebook page, Friday Hut Studios. Secondly, Lexa Student Association. They provided us with equipment and support since the beginning. And thirdly, everyone out there that gives us a like and a listen. Thank you. And until next time, take care.